Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, we're going to talk about pediatric tracheotomy, front of neck access for failed airway or foreign body airway obstruction in kiddies less than 8 years old. After 8, you should be able to do a cricothyrotomy on most children. But below that age, cricothyrotomy is not going to work. You have to do a tracheotomy, and that's scary. And you might want to retreat back to needle-based techniques. But as you'll hear shortly, those really don't work. They fail. And just like in adults, you need to pick up a knife. Now, I don't have the experience or knowledge to talk about this, so I got an expert on the systems-based thinking about this. Cliff Reid has spent, I don't know, it's probably years investigating this, trying to find the best technique for his Sydney HEMS service, in which he is the director of education, as well as the emergency department that many of the Sydney HEMS folks work at. And Cliff will tell you, he's never done one of these. He's just spoken to countless people and set up the systems for it. So that's what this episode is going to be, is talking with Cliff about, after speaking to pediatric ENTs, experts in the field, all sorts of people, what they came up with. But this is just a primer. And then on a subsequent episode, we'll have a pediatric ear, nose, and throat surgeon to talk about actual hands-on experience at the procedure. So this is the primer, and then we'll get the explosion with a pediatric otolaryngologist. Now, you definitely want to go to the show notes for this episode, emcrit.org/401. You'll find all of Cliff's slides and his quick reference guide and all of the references. But most importantly, you'll find a video that will really contextualize the technique. Because if you've never seen it done, then these words will be gobbledygook. On the other hand, if you watch that 3-minute video, you see what they're talking about, you watch Cliff actually perform it, and then all of the additional discussion will deepen your understanding of what's going on. So please, if you are by a computer, watch that video first. If you're not, then make sure you go and watch the video soon after listening to this to lock it all in. So we're about to jump in, but just a quick message, and then we will get into the show. Hey folks, real quick, a mention of our upcoming course, Unburnable. You might have also heard me call this Flameproof. We've changed the name. It's now Unburnable. And we are having our 4th cohort. I can't believe we've done it this many times. 4th cohort starting September 16th, 2025. And if you've heard me talk about this, you already know what it is, but really quick if you haven't. This is our virtual course that I host with my coaching partner, Rob Orman, on career longevity, anti-burnout, and self-mastery. Essentially, you will become unburnable at work. It will flow into your home time. You will be far more sanguine. You will like life more. You will start kicking ass. You will start wanting to come into your shifts rather than dreading it. Sunday nights will no longer be a disaster if you're working on Monday. It is 12 sessions, 2 hours each. We do every 2 weeks. So you're going to have us for 6 months percolating through your mind with topics like silencing your inner voice, your inner critic, agency and perfectionism, effective communication, shift overwhelm and efficiency, mindfulness and meditation, on-shift strategies to find joy, the fundamentals, things like sleep, life management and productivity, burnout prophylaxis, and then putting all of that together into a new system, a new strategy for enjoying work and life again. Everyone who has taken the course has given us positive feedback. For some people, it has been truly career-changing. And I think you at least owe it to yourself to check it out. If you are currently in the throes of the beginning or mid-stages of burnout, then you should take this course. If you never want to get to any stages of burnout, you should consider taking this course. So just come to Unburnable Course. That's one word, Unburnable course, because it's a course.com, unburnablecourse.com. Check it out. Look at the topics, look at the dates, see if this works for you. They're all recorded, so if you have to miss some of them, it's not a problem at all. You'll be able to watch the videos of your actual cohort and then still deal with all of the issues raised. There is a community that goes along with it. It's just friggin' fantastic. So if this interests you, come to unburnablecourse.com. All right, let's get to the show. All right, let's get into this. Cliff, everyone should know you by now, but just in case, just tell people briefly who you are.
I'm an emergency physician and I've worked in lots of countries, but mainly trained in the UK and Australia, and I live and work in Australia now. And I also have the privilege of doing some intensive care and spend half my time in pre-hospital and retrieval medicine, working out of Sydney.
And Cliff, you are the person I think most who I look to for training and creation of systems of excellence in emergency critical care. And recently I saw you at a conference and you didn't disappoint in that regard, because on my mental list for 20 years, there's been a little checkbox that's gone unchecked of figure out a good way to perform and teach pediatric front of neck access. And I think I just mentally kept pushing it aside, Cliff, because it's too hard and too scary. And then, and I didn't know this lecture was coming, you gave what I thought was, I don't want to put anyone else down, so I'll just say one of the best lectures at that conference. It blew me away. And it blew me away, first of all, because the lecture was done wonderfully and beautifully in your inimitable style. But more than that, it just, I think, was the apotheosis of your systems-based thinking for how to solve problems in retrieval and emergency medicine. So, Cliff, we're going to talk today about pediatric tracheotomy and what your system did to create a viable method of getting it done. So give me the nidus of this, Cliff. What took place that made this now was the time for you guys?
I've shared your discomfort over a similar time span of feeling like we need to fix this. How do we learn and teach this procedure and set our teams up for success? And it was on my too much to-do list for many years. And then we had our son in 2009, and it got me thinking a lot more about infant and pediatric airway emergencies. Now, for many years, it has been taught that whereas we usually recommend an open surgical technique for a can't intubate, can't oxygenate situation in adults, for children, we've recommended needle cannula techniques. And that's really not based on any evidence, but evidence started to accrue to suggest that was very likely to fail. Needle techniques, in fact, are probably more likely to fail in small children than they are in adults. And we can talk about why. So it was with increasing discomfort that standard guidelines and certainly what the Australian emergency medicine trainees were learning for their board exams was all about needle techniques in children, and yet the evidence was building to suggest that wasn't going to work. So we were doing a disservice to our patients and our trainees, and we had to fix this. But it's tough, and I think that's why everyone has filed it in the too hard basket for so many years. So,
I think any EM or critical care doc that has thought about this has made the mental decision erroneously that if I had to do this, I would just use a needle technique. I would put an angiocath in, and then I have all these jury-rigged methods that I figured out. Maybe they've even written down somewhere what they could attach to that hub so that they could bag the patient. And on every level, the evidence says that is not going to go well. That if you were even going to do a needle technique, it should be a jet ventilation setup, and that if you were going to use a needle technique, your chance of failure and complication is dramatically higher. Cliff, why do you think people still have not accepted the knife is better, even though we know that's the case for every other situation we've looked at for front of neck access?
I think it's partly because it is still taught. And in fact, a small unofficial survey I did of people who were instructing on the advanced pediatric life support course in Australia, there were qualified instructors that were teaching airway stuff on the course to do with kids and infants. And when I asked them, what does APLS say about the go-to technique for CAICO in infants? They all said, needle, that's what we teach. And then I would show them the APLS manual that actually suggested tracheostomy. And they were flabbergasted because at some point, what was written in the manual and on their guidelines and on the app that we have had changed, but it hadn't been widely publicized. And the instructors weren't even aware. Yeah, it's partly people just, I think, aren't aware. They don't read the literature. And the other thing is, it's such an exceptionally rarely indicated procedure. Not only have most critical care docs never seen it, they haven't seen a person who's seen it. To find someone who's done one and learn from them within critical care, emergency medicine, is next to impossible for most of us, which is why we went to pediatric ENT.
Tell us why the needle techniques fail even worse in young children, the 0 to 8 range, than they do in adults, before we go into further the actual technique.
Of course, yes, that's really important. So most people listening to this may well have practiced this in an adult mannequin, and we're taught to point the needle at 45 degrees to the horizontal, aiming downwards and penetrating in the cricothyroid membrane. And there's a number of reasons why that's not going to work in an infant or a small child. One reason is the cricothyroid membrane is more cranial in direction. It is often under the mandible. It's very hard to get to. And even if you can find it, you're not going to be able to go in at 45 degrees. You're almost going to have to go vertical, so perpendicular to the airway. So your force vector is downwards on a very collapsible structure. And the tracheal rings haven't solidified in a small child. So the airway is completely floppy and collapsible. That's why kids get croup and adults don't. And you're pushing down on a completely collapsible structure perpendicular to the skin. And the force required to penetrate the skin with a needle is greater than the force required to completely collapse the trachea. So you're inevitably going to go through a completely compressed trachea and come out the back. And if you're insufflating air through that, you're going to create massive subcutaneous emphysema and lose what chance you had of getting an airway. So it's physically impossible to get the 45-degree angle, and the forces required will collapse the airway and make it virtually impossible to get the needle reliably in the lumen of the airway. And the other thing is the cricothyroid membrane takes a while to become big enough to get a tube through. So the longitudinal vertical diameter of the cricothyroid space is smaller than a tracheal tube until you're quite a few years of age. Certainly not in the infant or toddler age group. You're not going to get a tube through there. And there's a risk of damaging the laryngeal cartilages by trying to... Essentially, we have to go low. We have to go trachea, not cricothyroid membrane. And needle techniques are likely to fail. So it has to be an open technique, and it has to be on the trachea, not the cricothyroid membrane. And people always ask, can I do a cricothyroidotomy? And the answer is when you can obviously feel it and it feels big enough to put a tube through. And if you have small children in your family or close relatives, with the child's and the parents' permissions, it's helpful when you're tickling them to just have a quick feel and see if you can identify a cricothyroid membrane. And the cutoff is usually around 8 years old, but it's very variable.
All right, give me a little history on your development of your technique for this procedure.
2011, I had the privilege of going to Minneapolis and learning from the team at Hennepin. They ran a life, limb, and sight-saving surgical course on live animals for rural practitioners. And this looked great. So we went there, a bunch of us from Sydney Hems, and they taught us an infant tracheostomy technique on anesthetized rabbits, which is a real eye-opener. That was my first introduction to how fiddly and delicate the process is and how easy it is to get wrong. And the technique that they taught, while effective, we found in the kind of kyco situations we might find ourselves in, we would probably be too slow at performing. Nothing wrong with the technique itself, but for our needs, we'd probably need to modify it. So that went on the back burner for about another 12 years. And then, of course, that same year, 2011, I think it was, NAT4 came out. So Tim Cook's team in the UK do these incredibly useful nationwide audits of anesthetic complications, airway complications. And NAT4 was a real game changer because that was the one, I think, that pushed adult critical care practice more into open surgical techniques than any other, I think, piece of information. And they showed that there was at least a 60% failure rate in needle cricothyroidotomy techniques in adults, and therefore recommended an open surgical technique, which was almost always successful, even when done by people that had never seen it or done it before. And at the same time, I was blogging, and I was blogging about papers on simulated infant and pediatric surgical airways, usually using a rabbit or a piglet model, showing big failure rates either from cannula techniques or from using proprietary devices on the market, but relatively high success rates with surgical techniques, again, in non-surgeons, untrained, relatively untrained people. So we really had to fix this. And one of the techniques that was recommended in one of the papers was cutting down to trachea, then getting some kind of purchase on the trachea. So using a towel clip, like I think it's called a backhouse towel clip, which has those curved pronged ends for gripping surgical towels and drapes. You can put that around the trachea and use that to lift the trachea out of the neck so that you have purchase on it, so you can then make the cuts in the trachea and put a tube in. So for a while, I had one of those at home with my infant airway kit in case I ever had to do the technique on my son. But that still wasn't good enough because I'd never really practiced it other than on that one rabbit. My colleagues didn't know how to do it. We didn't have the equipment in the ED or in our retrieval medicine service. So finally, I approached a pediatric ENT surgeon because, our emergency department, we're very lucky. We're supported in having a training day every year where we can just revise some resuscitated procedures. And we were doing an airway day for all of the emergency medicine specialists. And I said to a pediatric ENT surgeon, Sebastian Ranguis, said, do you think it would be appropriate to come and give our emergency physicians a teaching session on infant surgical airway? Obviously, we would always call you guys, but it might be middle of the night. You might be coming in from home. He went, absolutely. This is totally on my list of things to do. I really want to help with this. And I gave him like 3 days notice, and he turned up with a model that he'd created. He'd modified one of his daughter's dolls, removed the neck and put his own replaceable neck parts in, which were essentially 3 silicone straws, one in the middle for the trachea and either side were the carotid sheaths, wrapped in some sponge that he filled with fake blood, and then just tape around it just to hold it together. And it was a great model. We all got hands on.
Hey, folks, we're just going to stop for a second because this is a free episode. I'm giving it to you in its entirety, but it's very rare that we have these full free episodes because EMCrit is a members-only site that still has foam. But if you're enjoying this content, please consider becoming an EMCrit team member. It's inexpensive. You get CME. You could write it off on your taxes, but forget all that. What it's going to do is make you the best possible resuscitation and critical care doctor you could be. You'll have the most cutting-edge, up-to-date information, and you'll get it in the comfort of your car or on the subway or while running, and you'll never have to think, am I current enough or not? Am I taking the best care of my critically ill patients? All right, let's get back to the show.
He taught us the technique, and we had an appreciation for what it might be like, how small the structures are, how much it's likely to bleed, how easy it is to miss the midline, get the carotid sheaths. It's very humbling, but inspiring that someone from another specialty was so keen on us learning this technique that traditionally would be 100% within their domain.
That's fantastic. All right, Cliff, if you're amenable, I'm going to take you through your current iteration of the procedure as is indicated by this beautiful quick reference guide that we'll put in the show notes. And then maybe you could tell me the evolution of each step as we go through it, where you came from, the various things you tried, and why you wound up where you did.
Sure, yeah. And I think it's really important to say that this is a surgically inevitable airway. This is when the team has made the decision we don't have an alternative, we have to cut, because it's not easy. The first one you do is probably going to be the first one you've seen. And you've got to be absolutely sure that this is the right thing to do for this patient, ethically, legally, clinically. So we've discussed this before. It's about making the decision ahead of time. It's not if, it's when I deal with an infant or a small child and I can't intubate, can't oxygenate situation, and I've tried everything else, I will do an open surgical tracheotomy to the best of my ability. But even with that, as leaders and designers of systems and as educators, we have a responsibility to our teams, if we're expecting them to do it, to back them up as much as possible with SOPs, with training, and so on. Because it's hard to imagine a more stressful procedure than this. Often the parents are in the room during a pediatric resuscitation. You're cutting a hole in their baby's neck. You've never done one before. You may have never seen one before. Everyone in the room is going to be thinking, what the fuck? So unless you've made these decisions in the past, a lot of people are going to understandably talk themselves out of it. And if there is a needle cricothyroidostomy kit in the drawer there, they're going to reach for that because they're human. Who wouldn't?
The retreat to safety. Absolutely right. Now, what makes this worse, Cliff, and I think this is a good entryway into the procedure, is you and I both teach aggressively that adult cricothyrotomy is a blind, no retractor procedure you do by feel, and that light, suction, or any form of retraction is completely unnecessary. And we pound this into people's heads. And now things are a little different for pediatric tracheotomy. So tell us about that part first, Cliff.
Yeah, this is so important to get our heads around. And I struggled with this for a while. As you say, we teach adult cricothyroidotomy as a tactile procedure because we're expecting it to bleed. So we're not expecting to see the structures that we want to enter with our blade, our bougie, our finger, and so on. But you just can't do that with the infant airway because you've got a small, floppy, slippery structure in the middle, which is the trachea, and then you've got small, floppy, slippery structures very close either side, which are the carotid sheaths. And one of those you want to penetrate, and two of those you don't. So you have to see what you're doing. You won't be able to feel tracheal rings because they're just not hard. And you've got to get through subcutaneous tissue, fat, often have to cut through thyroid, and that's going to bleed. So you're expecting to have to look for this trachea. You have to look for and identify tracheal rings. When you see the rings, you can cut through that structure. So it's really tricky.
So now you guys have in your kit a headlamp so that you have the ability to have good lighting wherever you're working. You have suction and you have retractors so that this is going to be like very close to an operative tracheotomy where you're actually going to be seeing what you're cutting versus just hoping and praying based on your finger feel where you're going. So that's the first real sea change in the mindset on this procedure. So let's walk you through the steps and you tell us about it, Cliff. Position patient neck extension, but avoid hyperextension in infants, which may flatten the airway. So what position are you actually obtaining in these patients and how are you doing it?
So it's going to depend on the size of the child. But in the model that we've built that we haven't spoken about yet is based on a 9-month-old infant. And we're exposing as much neck as we can with some head extension, but we're also supporting the head to stop it rolling. This big, floppy, heavy infant head is going to roll from side to side and you're going to lose your midline. So we'll use bolsters either side of the neck to stop the neck rolling. And then an arrangement of towels under the head and shoulders just to get the exposure of the anterior neck, avoid flexion, but avoid hyperextension. But there's definitely more extension than flexion to see as much neck as you can. That's important. And as you say, light sources are critical. And for us, we're pre-hospital specialists too, so we can't rely on external light sources. We have to bring our own. We're going to discuss one particular approach. I have no expertise in this. This is a personal journey. I'm an enthusiast in lots of things. I'm not an expert in many. So I'm an enthusiast in this, but I've never done one in a live patient. So take everything I'm saying with a pinch of salt. This is a solution that we've come up with for our practice, but I'm talking without any degree of personal
It's a solution
experience.
you developed and vetted with a pediatric ENT surgeon. Is that correct?
Sure.
Yes.
Yeah. But there are also alternative approaches done by brilliant people who are equally as driven as we are in solving this. There's teams in the UK, there's teams throughout Western Europe, Northern Europe. In fact, I've communicated with people from 9 countries during this journey, comparing notes, and there's been this kind of parallel evolution. And there's a technique that you can easily find a video of online. I'm sure you'll link to it. I think run out of Denmark. That's very different from this one and arguably is simpler. So I'm keen that listeners find a way that they and their teams are comfortable with their input from their local ENT, obviously.
For sure. I'm going to walk you through each step. So we've positioned the patient. Now, another thing that's distinctive from adult front of neck access is this is a 2-person procedure, a 2-clinician procedure. You need both of them to be skilled. You need a skilled assistant to perform this. It's not a solo operation. So the person who's the operator is going to be on the side of the patient of their dominant hand. And then on the other side of the patient is going to be an assistant who hopefully has had the same training. And you folks have gone so far as to put all of the equipment for either role in a rolled up, I guess you just call it a roll, right, Cliff?
Cool.
That when you unroll it, there's half for the assistant's equipment and half for the operator's equipment. And we'll put pictures of that in the show notes. So, Cliff, you're a righty, if I remember. Is that correct?
Correct, yeah. So I would go to the patient's right. How we do this currently, our skilled assistant is at the head end.
Okay, great.
Because they're doing the retraction, so they need great appreciation of midline. And we found that was harder doing it from the side.
Oh, I love that. So now you're identifying midline. Now, Cliff, you have here, there's a marker using a pen to the nose, the chin, the sternal notch, and the xiphosternum. Tell me about this. And when I look at that, on face value, no pun intended, could the nose and chin not throw you off if the head's slightly turned?
Yeah, absolutely. Yeah, so coming back to bolsters, keeping that head in the midline and then identifying the midline by drawing it on the patient with a marker pen is what was recommended to us by Seb, the ENT surgeon.
And if you just came up from the sternal notch, how would that send you astray?
How do you mean?
If you just establish midline by finding sternal notch and saying, this is my midline, and then just drawing a line up from there?
Yeah, if I put my finger on my sternal notch now and I turn my head to the left.
Oh, absolutely. If the head's turned, we're going to have some problems here. But assuming, like you said, you have a straight on head, what does the nose and the chin bring to the picture?
To be honest, I'm not sure. That was recommended by the pediatric ENT surgeon. I just wonder if in smaller infants, some of these clinical landmarks might be harder to find. You can imagine a chubby baby, the sternal notch might not be obvious to palpate.
Gotcha. Okay, that makes sense. And then anything else we need on midline? So you guys are actually drawing that line, or are you just making dots on the nose and chin and then drawing a line down the whole neck? What do you actually do with your marker?
We draw the line. Because we've built this dedicated mannequin with replaceable neck parts, we only draw on the replaceable neck parts.
Good. And on a real patient, obviously.
Drawing. Yeah.
The Sharpie is the least of their problems.
That's right.
Okay. So you've identified midline now, and now there's going to be a vertical skin incision. And there's a clear prohibition about avoiding the lower quarter of the neck and staying midline. And you have your non-dominant hand, the thumb and index finger, actually stabilizing the larynx. Tell me a little bit more about this, Cliff.
Yeah, so it's almost like the laryngeal handshake, but our non-dominant hand is fixing those structures, pinning down the skin so the skin is taut, not going to roll over the airway, and you don't want that airway to move while you're doing your initial incision. And we avoid the lower quarter of that space in the neck, just above the suprasternal notch, because, often the innominate vein will run across that in the infant, and the carotid sheaths either side, the innominate vein there, those are structures that Seb describes as difficult to fix from his ENT.
Understated.
You don't want to mess with those. It's going to be bloody enough. You don't give the patient a C problem as well as an A problem.
Yeah, that's fantastic. And it's funny, I've trained in adult surgical tracheotomy. I've never done a pediatric one, but we often go in the lower quarter of neck in adults. So it's another difference from the standard thing that even people experience with that may be used to. Since the innominate could poke above that sternal notch, we're going to avoid that area as well. Okay, so now you have a cut. How big is the cut, Cliff?
So it needs to be generous. And it's important to realize the ENT people tell us it's hard for us to do unfixable damage to the airway. If we're saving a life, just get in there. And so it's a generous incision in terms of length. Just like if you're doing a thoracostomy. The commonest mistake our trainees make is to try and do keyhole surgery, and you want a decent incision because you've got unpredictable tissue depth to get through as well. And the nice thing about our model is all the neck parts have reasonably random, definitely variable subcutaneous tissue thickness, so that we've done that deliberately so we don't get a training scar. We're not expecting the trachea to be at a certain depth. We have to hunt it and find it. So you're cutting through, it's going to start bleeding, there's going to be fat and stuff. And then, it's a combination of gauze, suction, and retraction. We won't have diathermy in the ED or pre-hospital to be able to see through the blood, to remove the blood, see through the blood, and look at what you're doing. I'll usually have a bit of gauze on the chest. I'll have my left hand pinning the airway. I'll have my right hand cutting. The assistant's ready with suction and retraction. A cut starts to bleed. I might dab it with gauze myself as I continue to cut, and the assistant gets ready with the retractors. We've drilled this as a two-person procedure because our standard pre-hospital configuration is a critical care physician and critical care paramedic. But usually when we're on scene, there are other providers there. It's preferable to have a third person with the suction because you just need so many hands for this. 2 hands on the retractors from your assistant and your 2 hands pinning and cutting the airway. So a third person can manage the suction if necessary.
So if we had to break the neck into quadrants, it sounds like you're making a cut from the entirety of the second and third quadrant. You're leaving a little bit at the top, you're leaving a little bit at the bottom, and you're cutting everything in between. Does that sound right, Cliff?
Yes. Yeah, that's a good way of describing it.
All right.
And at some point, you'll cut through thyroid. There are vessels associated with that, obviously. So there's more bleeding, more suction required, more retraction, and a good light source. So when Seb was teaching us, the mantra was midline, suction, retraction. That's what gets you to the trachea. Do not lose the midline. And you can imagine if your assistant isn't having a good day, or they're inexperienced, or they haven't picked up the retractors before, maintaining that midline might be a challenge for them. And in training, we've on several occasions, we've picked up the trachea with our retractors and pulled it to one side, and then the operator's trying to find it.
Yeah, that could be a problem.
And this is why you have to train this. You need a good model. You don't need a perfect model, but you need a good model. So the team gets to share the mental model about what they're trying to achieve together. Yeah, it's one of the halo procedures, high acuity, low occurrence. But yeah, we say without training, it becomes a FAFO procedure. Fuck around and find out. You fuck around with this and you haven't done it before, you're going to find out pretty soon how hard it is. That's why I think it's the most challenging halo procedure, certainly that we train within our skill set.
So I want to go into the retraction step, which I think is where we're at now. So a few things. One, you've just cut skin at this point. Are you getting retractors in at that moment? And then do you actually specifically train your assistants on how much pressure they should be exerting?
Often if you've just cut through skin on our model, again, because I haven't done this in a live child, at least, you're not going to fit the retractors we've got around just those layers of skin. So we're still using our non-dominant hand to pin the tissues back, pull them apart as we're cutting, can provide some degree of hemostasis as well from the tension and the pressure. Yeah, and essentially when the tissue thickness is big enough to get the retractors in, that's when they go in. We're using small right-angled retractors because they're simple, but there is a technique to them. Yeah, I'm not a trained surgeon, but we find that the commonest mistakes people make are pushing down rather than retracting outwards, and also being quite skewed in terms of angle. They're holding them diagonally, so one's coming more down and out, and another one's coming more up and out, and that's distorting the tissues.
Yep.
So when we're training the assistants, we really want them to have those retractors definitely horizontally, and for their force vector to come out laterally, pulling the tissues apart. And again, it doesn't have to be this. You can use towel retractors, the backhouse clamps, to clasp the tissues and strap muscles on either side and pull those out of the way. And that looks really good. When you see examples of that technique on the videos, it does look very doable. The problem we've had when we've tried to apply that is we haven't been able to find any examples of these retractors without extremely sharp, pointed tips. And so in our training model, we've torn the trachea with them, we've torn the carotids, we've torn my index finger.
Yes.
We've stayed away from them because the ones we've been able to get hold of are so sharp. But if that's what works for you, and that might be a better option if you're a sole provider or you have very unskilled assistants, you might have to rely on that because you can put them on, clamp them, and leave them pulling the tissues apart.
Yeah, that answers the question I was going to ask, which is why you stayed away from them. And you're right, they don't exist without being super sharp. The tallow clamps are built to puncture, so they have to be sharp. So that makes total sense, and I could just see a disaster coming from having a pincing set of basically needles on the field. I wonder, did you guys ever speak about the self-retracting, the ones that look like scissors with two rakes at the other end, that when you start squeezing the scissor, that would be what we usually would use for small incision like this for someone without skilled assistance. Did you guys try that on the models at all?
We haven't tried it. We used to have them as part of our adult crike set. And in training, it would just confuse the hell out of people that weren't used to using them, because we don't really use them in any other aspect of our practice in emergency. And it's, if you haven't picked them up before, it's counterintuitive, isn't it? Which way you
absolutely
apply them.
All right, so now it all makes sense why you've chosen these straight right angles as retractors. And now they're going to be retracting as soon as you get to the point where they could pick up the strap muscles on either side. And now you're going to continue to cut down until you can actually visually ascertain tracheal rings and tracheal structure. On the models, at least, Cliff, how many cuts does this usually require?
Yeah, that depends on who's cutting, because you tend to see people's lack of surgical training when they're doing this. And yeah, you got the people that think they're doing some kind of pencil sketch, and then you've got the others that are doing a more, you know exactly what I'm talking about.
I do. That's a perfect way to describe it.
And the others that do a more definitive cut and they're straight down trachea, and you think, maybe you hold back a bit
too
next
much
time.
on that one. Yeah.
It's very variable, but yeah, 2 to 5, I guess, somewhere around there, depending on the thickness of the model and the skills of the operator. But I think you've got this balance between every second counts, because you're going to have a hypoxic brain, and being able to see what you're doing nice and carefully so you don't overshoot or miss the midline. So that's hard. So Natalie May and I have worked on this for the last few years together. As you know, Scott, she's a pediatric emergency physician and retrievalist and all-round legend. And we've probably done 100 of these between us. She's much better at them than I am. And she'll do a nice, comfortable one while teaching it in about 1 minute 20. I'm about 10 seconds slower. I can do it faster, but that's when I FAFO.
Yep, I hear it. And we should talk about that towards the end, because I think that's an incredible number. That a group that's trained that much, it's still, that's what you're talking about here, is over a minute. And looking at the ENT surgeon who was masterful, I don't think his timing would be that much quicker either. I don't think this is one of those 15-second procedures. And that's worrisome, because if this is being done as a rescue rather than you've had the patient temporized, then you just realize we can't get a definitive airway, but we're not satting in the toilet. A minute 20 or even a minute, that's a long time.
It is a long time. And if we think about the clinical scenarios in which we might have to do this, if you're in the emergency department and it was a pre-hospital event, inhaled foreign body or something, your best outcome is probably going to be a brain dead kid on ICU donating organs whose parents can say goodbye, rather than someone going straight to the morgue.
Yep.
So all of this effort over years to design this system and get the training for that outcome, is that worth it? And of course, the answer is fuck yes.
Yep, we're going to do it no matter what.
But you can imagine other scenarios where you've got an evolving kyco situation in hospital. It could be an anaphylaxis in an infant. That's perfectly plausible.
Yep.
And help is just not there.
Yep.
Even in a big center, help might not be there in time, let alone a remote or rural place. So I think we absolutely have to have this procedure in our skill set if we're responsible for pediatric resuscitation.
100%. All right, Cliff, we're on step 6 here. And now we've visualized tracheal structure, and we're actually going to cut the rings. Now, originally, I watched the evolution of your kit through the various publications you did, and in your early thing, you did have the tallow clamps there, one of them, not for the retraction, but to actually do the lifting of the trachea anteriorly into the field. And it sounds like you got rid of that for the possibility of iatrogenic injury of structures or providers. So now you're not lifting it, you're just visualizing it in the field. And then at some point you had scissors in there to actually plunge into the trachea and cut vertically through 1 to 2 tracheal rings. And now even that has disappeared in a streamlining effort. So now you're actually making the cut into the trachea with a scalpel. Is that correct, Cliff?
That is correct on the quick reference guide that you're looking at there. But the evolution again has been cut to the scissors. This is where, like, you get an airway, right? It doesn't matter if you use scissors or a scalpel. So it's personal preference. Nat prefers the scalpel because she's highly skilled. I prefer the scissors because I've cut through the posterior tracheal wall with the scalpel twice now. And I've done this procedure many times. So to expect my colleagues to have 1 or 2 training sessions and not to make the same mistake is unrealistic. So I like the scissors. It's hard to plunge the scissors all the way through, and they're really nice. It's a really nice feel cutting through a couple of tracheal rings. And of course, just reminding the audience why we're doing that. There's not really enough space between the tracheal rings to make a horizontal incision and place a tube like you would with a cricothyroidotomy in an adult. So you actually have to remove a bit of tracheal ring by cutting through the anterior part of them, usually at least 2 tracheal rings to fit the tube through. And then we've gone bougie. We were taught not to use a bougie to start with, just to put the tube in the hole. But we realized, certainly for our physician paramedic teams, we use a bougie for everything. We use a bougie for our cricothyroidotomy, for our rapid sequence intubation. We're just used to putting a bougie in a hole, then a tube over a bougie. The 2-person communication pattern we have is optimized. We're so at home, we've elected to do it over a bougie.
Makes absolute sense. Let me just go back to step 6 for a second, Cliff. So you've mentioned cutting 1, usually 2 tracheal rings, which we'd have to do in an adult as well. Even in an adult, there's not enough space between the tracheal rings. You have to cut at least 1 in an adult. So you're cutting these rings. Which ones are you going for? And I've seen published the first and second tracheal ring is in general, and being that you're not in the lower quarter of the neck, that makes a lot of sense. Is that what you're actually seeing? Are you actually visualizing the nascent cricoid cartilage and actually counting? Or are you just saying, wow, that's midline of trachea, I clearly see rings, I'm just going to cut? How?
That one, the latter. We are so relieved to see rings. Sometimes we've had to cut through thyroid to see the rings. Sometimes the thyroid's relatively intact and we found the rings below it. So yeah, and even when we finished the sim and we're going back and we're looking at the model, we're not really counting which ring it was. If we're in the airway, we're just so happy.
Okay, perfect. And now bougie goes in and tracheal tube goes in. Which tracheal tube is in your kit that you know will easily pass over the bougie? What size?
So we have cuffed 3 and 4 in our kits, and we have an appropriately sized bougie for that. We're still playing with different manufacturers' bougies. We haven't found the perfect infant bougie yet.
And then from that point, obviously, you sink it just until the cuff disappears, inflate, and confirm with end-tidal CO2.
Yeah, just seeing the cuff just go in the wound is so important, obviously, because there's so little space between your entry site and then the bifurcation of the trachea. So we don't want an endobronchial intubation, although that's not the end of the world if we get that. If it's in the right organ.
If you get it that, then we'll call you a winner. Okay, Cliff, what have we not spoken about on the procedure itself that we should have before we go into some of the evolution of how you made this all happen with the mannequin and the various training iterations?
Maybe the end and the beginning of the procedure. So end of the procedure, once you've inflated that cuff, bougie's out, connecting to end-tidal CO2 every time. You need sustained exhaled end-tidal CO2. Even if the patient's in cardiac arrest, you need to see end-tidal CO2 or it's not in the airway. And in terms of securing the tube, we haven't devised a system yet for that. Clearly, You want to allocate one responsible clinician to hang on to the damn thing while other people are responsible for progressing the resuscitation, and then worry about how you fix it afterwards. And then before the procedure, for airway obstruction, I think like anything else, it's fine to have an algorithm of steps, but you might add steps or omit steps depending on what's caused the presentation. Your airway could be obstructed because of an intraluminal problem, like an inhaled foreign body, or it could be the walls of the airway itself swollen from anaphylaxis, burns. It could be extraluminal compression from a tumor or a bleed. So just thinking about what's going on, why you've got this problem in the first place, will help you then decide what steps you might want to try before you head down the surgical airway, because it might not be surgically inevitable if there's another way of sorting things out. So if you've got a means of retracting a foreign body endoluminally and you have time to do that, clearly that's better than cutting a hole in the neck. And if you have an inhaled foreign body that's mobile or compressible, or you can break it up. Often kids will inhale on vegetable matter. It might be some leaves, cabbage, or something. No, kids don't eat cabbage, but there's that joke, isn't there, about broccoli and boogers? What's the difference between broccoli and boogers?
Yeah,
You can't eat broccoli. If they didn't chew their veggies and they're in their airway, then of course we all know you can try and intubate, and if you can't ventilate through the ET tube because of an obstruction below the tube, you can advance the tube itself to push the foreign body into one of the main bronchi. Or if you can break it up, you could put the bougie through the ET tube, try and break it up that way. If that works, I would rather do that than cutting a hole in the neck and so on. You may have equipment in your ED where you can extract a subglottic foreign body. And there's kit that we've been playing with that might be useful for that. So those things I think are important to bear in mind.
All right, fantastic. Cliff, you guys are training on this, but obviously if you're going to train, you need something to train on. And the story you told about how that evolved was just delightful. So just give us a very brief explanation of Emma and the work she did.
Yeah, so we were inspired by Seb using a very basic model that he'd created that provided so much fidelity that I asked my friend Emma Laird, who's a New South Wales ambulance paramedic, to see if she could come up with something similar, because for several years she had been helping us with our Sydney HEMS induction, creating really good makeup and part task trainers for our simulations. She even designed a really good wearable hysterotomy model so we could have an actor being the arrested pregnant mother, but that we could perform a hysterotomy on them. So I knew if anyone could do this, she could. And I said, can you make me an infant neck that has replaceable parts? And she went away, and she's very busy. She's a young mum and has loads of other responsibilities, but got back to me 11 months later. And because I was going, where is it? How are you going? Need any help? Can I do anything? She goes, no, I'm doing it. And then she turns up. She said, I'll bring the model down to you. I'm in Sydney next week. And she bought this whole infant mannequin that she'd made that anatomically was amazing. It had taken her 11 months. It has incredible neck anatomy that bleeds, that has a thyroid, that has a trachea, that has carotid sheaths, subcutaneous fat. But also, if you go through the mouth, it has the best laryngeal anatomy I've ever seen for an intubation mannequin. It's even got a really realistic median glossoepiglossic fold, which if you engage the epiglottis flips up. It's nuts, Scott. It's nuts. It was just amazing. And what she'd done is she taught herself 3D printing from CT scans, clay sculpting, silicone modeling, had spent several $1,000s of her own money on the materials, set up a workshop, and essentially became infant Frankenstein and just created this incredibly lifelike baby, which she named Hemsworth. That's what he's called. So obviously we paid her for it and didn't want it to be out of pocket because we'd love her to use her genius for more models. And she's in the process now of setting up a factory and being able to make her work more scalable, because 11 months to make a baby is longer than it takes to make a real one. So this thing's pretty precious, really. We've only got the one. But I'm sure we can provide a link to people that...
We 100% will. Cliff, is there anything else we missed talking about that we should?
I think if you're a leader in an emergency department, a pre-hospital system, a PICU, and you think you've been convinced by this podcast or other things you've read that this is something your team should be doing, then take ownership on behalf of your whole team. Find a way to train them as realistically as possible. Create the systems so that you're not relying on an individual expertise. For example, in our department, we had the Halo trolley. There's a clearly marked pediatric surgical airway drawer. You take it out. There's a laminated checklist, which an assistant reads off, confirms the indications. And then if you'll go, you do it. And the equipment, sterilized and ready, is all laid out as you need it in the drawer, good to go. And someone has to be responsible for maintaining and checking that. Because it's just hard to imagine asking a member of your team to do something more challenging than this. So own it on their behalf.
I love it. And that's the exact system-based excellence that I was referring to at the very beginning. So we come full circle. Cliff, I can't thank you enough. We're going to be hearing, hopefully, from you much sooner than in the past until the next episode. And I just can't thank you enough for all the stuff you do and then sharing it with us.
Thank you, mate. And I appreciate the chance to talk about this. And if I can give a final shout out,
please,
to Nat and Jacob and all the critical care paramedics that have invested their own expertise in the logistics and ergonomics of this. We couldn't have done it without them. And again, all the people around the world, from Hennepin 14 years ago, all the way through to people in Southampton, the UK, and Italy, Switzerland, Austria, the Netherlands, Denmark, New Zealand, Australia, Emma, all these amazing people. It's been a team effort over a decade and a half. And we're still not there yet. We still haven't rolled out the training and formalized the equipment in our pre-hospital service yet. So it's a work in progress, and I'm just grateful to be part of such a great worldwide team.
Perfect.